Uh, welcome to the Breaking Barriers and Shattering Stigmas for South Asian LBT Women's Sexual Health and HIV Medicine event. I'm Siddhi Joshi, and my pronouns are she, her, and hers. And I'm the founder of the British Asian LGBTI support group, which is an online support group for South Asian LGBTI individuals in Britain and Ireland. My co-host Dorjinder Johal of Gaysians, who works across production, marketing, and journalism, in addition to being a writer. Dorjinder works with companies across the UK, including the South Asian LGBT plus organisation Gaysians. So Dorjinder, I'll hand it over to you.
Thank you for that lovely introduction, Siddhi. I'll keep it brief just because I know you're here to hear from our brilliant speakers today, but you can find our work online at Gaysians, and I'm all over Twitter as well. So please continue this conversation online with us. We organised this event as we felt it was a much needed event in the South Asian community. Sexual health disparities remain present for South Asian women, and the reasons behind that are really complex and may include taboos around accessing sexual health services. Furthermore, LBT women face additional barriers to accessing healthcare due to phobia, biphobia, transphobia, and misogyny, both within the South Asian community and in wider society. Each speaker will be making a presentation for the first hour, followed by a panel discussion during the second hour. I'm just going to hand over to Siddhi to introduce our wonderful panelists for today.
Okay, now I'd like to introduce our three wonderful panelists. This webinar brings together Dr. Rageshri Dhariwan, an NHS consultant, Dr. Selina Singh, and Neelam Hira of the organisation Sisters. Dr. Rageshri Dhariwan is consultant in sexual health and HIV medicine at Barts Health NHS Trust in East London, and honorary senior lecturer at Queen Mary University of London. Her research and advocacy focuses on reducing health inequalities, particularly for women of colour. She's the co-founder of SAHAR, the South Asian HIV Advisory Resource.
Then we have Dr. Selina Singh, who is a consultant in sexual health and HIV medicine at Barts Health NHS Trust in East London. Her specialist interests are the sexual health of young people, managing STIs in pregnancy, and the management of recurrent or persistent conditions such as thrush, bacterial vaginosis, and genital dermatosis. Finally, but by no means least, we also have Neelam Hira, who is a TEDx speaker, founded Sisters after facing her own battles with diagnosis and care, and wanting to address the health inequalities faced by those from communities of colour and the LGBT community. Most recently, the organisation have changed their name to become inclusive of trans communities, as well as by removing the word woman. Neelam's work has been recognised by the Pride of Britain and Point of Light Awards from the Prime Minister. And then, without further ado, I'd love to welcome Dr. Rajeshri to present.
Hi everyone, I'm just going to attempt to share my screen, so just give me a minute while I do that. Hopefully it'll work. And great, here we go. Can you all see me? See my screen? Yeah, great. So thank you for the introduction, and thanks so much for the invite as well. So I was really lucky to speak at the British Asian LGBTI conference in Birmingham a few years ago, which was face-to-face, and it was a real honour to speak about sexual health then, and it really got me thinking and actually led to some research on HIV in South Asians, and led to us creating SAHAR, which, as as was mentioned, is the South Asian HIV Advisory Resource, because we realised that HIV and sexual health weren't being talked about enough in South Asian communities. So I'm going to talk today about HIV, and this is, so I'm a doctor. I spend most of my time doing ward rounds in clinics and a bit of research, and I'm based in East London in Whitechapel. So I'm going to talk about HIV. So bear with me, here we go. So some of you may have watched It's a Sin, which was on Channel 4 earlier this year, which was a 5-part drama by Russell T Davies about HIV in the early 80s. And it was around a group of people who were living in London at the time. And if you haven't watched it, I would highly recommend it, because I think, one, it's a very moving and very well written show, but it also really shows what HIV was like in the early 80s and all the issues associated with it, including stigma, homophobia, etc. So I think, first of all, that I wanted to point that out because HIV is quite topical at the moment. And to start off, what I'm going to do is talk a bit about what HIV is like now, because I think if you watched that and didn't know what's happened since, you might still think that HIV was not a treatable condition. So things have really moved on since the early 80s. So in terms of where we are with HIV now, we actually have an international target of ending AIDS as a global epidemic. So UNAIDS set this target back in 2014 to end AIDS and HIV as a public health threat by 2030, and to make sure there were no new transmissions of HIV by 2030. And what they did was they wanted to make sure that 90% of all people living with HIV knew they had HIV, so they'd had a test. They wanted to make sure that of those people who knew they had HIV, that 90% were on antiretroviral treatment. And of all those people on treatment, that 90% had what we call an undetectable viral load, which meant that they were on effective treatment. So that was the aim. And how are we really doing in the UK? Well, first of all, to say we are doing really, really well. So this is data from 2019 from Public Health England. And in terms of the figures in the UK, we have 94% of people who have HIV diagnosed. And of those people, 98% of them are on treatment, and 97% are virally suppressed or undetectable. So in the UK, most people know they have HIV, most of them are on treatment, and most of them are on effective treatment, which is really great news. You can see that the lowest percentage is 94, which is still well above the 90 target. And we still have about 7,000 people in the UK who don't know they have HIV. So we still have a bit of work to do to try and find them. And in terms of HIV, we have amazing drugs now. So in comparison to It's a Sin, where there were no drugs that were effective, in 1996, researchers found that by putting 3 drugs together, we could effectively control the virus. And now we know that if people are diagnosed before the HIV has got too advanced and they're put on treatment, they can expect to live to a normal life expectancy. So we really think of HIV now as being more of a chronic disease for which people take tablets every day, a bit like diabetes. But of course, it is different in many ways because there's less stigma with having diabetes compared to having HIV, for example. So something that still really needs to be worked on. And because we have really effective treatments now, we now know that the people that we see in clinic are getting older. And you can see from this graph here that even just in a 10-year period from 2007 to 2016, the proportion of people aged over 50 was getting higher in our clinics. And this is great news because it means people are getting older. And as HIV doctors, Selena and me have to now learn how to deal with diseases of older age, like treating blood pressure and heart disease, and have to relearn all of that again. That's good. And also we're picking up people who are getting their HIV when they're older, because of course people don't stop having sex once they reach a certain age. So it's really important that when we are looking at testing people, that we also include older people as well. And one of the really big findings has happened in the last few years. And this is the finding that if someone has an undetectable viral load, which means that they're on effective treatment, that the amount of virus in their blood is so low that we can't measure it, it means that they're no longer infectious. They can no longer pass on HIV to anybody else. And there is a global campaign to raise awareness of this, and it's called U equals U, or undetectable equals untransmittable. And this is really huge because I think for a lot of people living with HIV, there's always been the concern that they might pass it on to their loved ones or other people. So knowing that they are uninfectious because they're on treatment has really helped with self-stigma. And it can help us end the epidemic, because if say everyone who had HIV was diagnosed and on treatment and was undetectable, no one will be passing on HIV to anyone else. So this is a really good news story. So if you're watching It's a Sin, you may have noticed that there were no women there living with HIV. And of course, there were women living with HIV in the early 80s and since then. And the invisibility of women in the HIV sphere has been something that's been really pointed out over the last few years. And there was a big campaign a few years ago by the Sophia Forum and the Terence Higgins Trust in the UK. And this was to try and raise the visibility of women in the HIV response. So this is invisible no longer. So I'm going to talk specifically about women now. And I think it's particularly perhaps strange that women have been so invisible in the HIV response, because if you actually look at the global figures, and I'll put a big arrow there to show that, there's actually more women living with HIV globally than there are men. So there's about 19 million women living with HIV and about 17 million men. So the fact that women have been so invisible, I find worrying, and we can see why there's been campaigns to try and reverse that. And if we look specifically at the UK, so there was no specific report looking at women living with HIV in the UK until 2018. So this is the first one that looked specifically at women. And what they found was there's about 28,000 women living with HIV in the UK, of which 114 were reported as being transgender. And women made up about 31% of people living with diagnosed HIV infections. So although globally women make up the majority, in the UK they make up about a third of people living with HIV. Around 1,106 new diagnoses in the year. And of note, 50% were diagnosed late. So what does that mean? So we say someone is diagnosed late with HIV when the virus has had time to damage the immune system. So if someone has had the virus for a few years and didn't know about it, there would have been time for the immune system to be damaged. And late diagnosis is really important because it's the biggest predictor of HIV-related death and illness. So that's why it's really important that we diagnose people early. And the fact that half of women are diagnosed late means that we need to do more to get more women testing. In the past, there was a lot about how it was people coming from overseas, bringing HIV into the UK, but actually we know now most HIV is acquired in the UK. And it was estimated in 2017 that 57% of all women newly diagnosed probably acquired their HIV in the UK. And again, if they're getting it in the UK, why are they not accessing HIV prevention tools which could prevent them getting it? And of course, it's when we think about women, it's important to remember that there are different types of women. And one really important thing about the epidemic in the UK is in terms of women, 80% of women living with HIV in the UK are from racial minorities, particularly Black African. There are also Asians living with HIV and Black Caribbeans, but when we think about it, it is a racialized epidemic in the UK, and that's something we need to think about. So why is it that we have these differences? Why are women so affected by HIV globally? And in fact, in terms of new infections, we are seeing worrying trends in some areas of the world. So for example, we know that globally 3 in 5 new HIV infections amongst young people aged 15 to 24 are in women. So that's about 5,500 young women a week. And that's particularly coming from sub-Saharan Africa. We also know that trans women are more at risk of getting HIV. So a meta-analysis of data from 39 studies conducted in 15 countries reported a global HIV prevalence amongst trans women of nearly 20%, with trans women estimated to be 49 times more likely than other adults to be living with HIV. And there is some evidence that perhaps women are more biologically susceptible. So perhaps it may be related to what we call the vaginal microbiome in cis women. So thinking about the different bacteria that are in the vagina and whether they make it easier for HIV to pass across the lining of the vagina and into the bloodstream, and whether there's any effect of sex hormones, which may make the lining again of the vagina perhaps a bit thinner, again making it easier for it to tear slightly and to allow transmission of HIV across. However, that data is not conclusive. There's just suggestions of that so far. Once women do get HIV, there doesn't seem to be any difference in terms of how effective it is. So we think antiretrovirals are just as effective for everyone, but there are possible differences in tolerability. So there are studies that show that some women perhaps get more side effects from antiretrovirals. And that may be because they may have differences in the amount of fat and muscle in their body. So drugs may be absorbed in a different way. So the levels might be higher in some women, which may give them more side effects. And that's important because if it's difficult to take medications every day if you're getting side effects from them. But what we do know is that HIV disproportionately affects cis and transgender women and adolescent girls because of vulnerabilities created by unequal cultural, social, and economic status. And I'm just going to briefly talk about some of those issues now. So I think one of the things we need to think about are kind of traditional gender roles across the world. So we know that in many areas in the world, women have less access to education, and there are studies that show that if girls don't get access to secondary school education in some countries, they're at a higher risk of getting HIV. They tend to marry earlier, have children earlier, and have less autonomy over over who they can have sex with. We also know economic empowerment is a really important thing. So when we think about the gender pay gap, for example, which we see globally, if women have less economic empowerment, again, they may be more likely to get married early and have children earlier, and maybe at higher risk of getting HIV. And that's been shown in some studies in sub-Saharan Africa. We also know that women often are the carers of the world. So when we think about unpaid labour, I think it was the Carers UK Association estimated that in the UK, the amount of caring done by women equals £77 billion. So that's £77 billion of unpaid labour that women do. And obviously, again, this impacts on their economic empowerment and ability to choose what they want to do with their lives. There's also the second shift, and that comes from a book that was released in the 80s, but essentially it's the notion that women go to work and then they come home and then they may need to do a second shift, which means they then may do more housework, may need to do the cooking, maybe more likely to look after the children. And all those things can really impact on their time and their ability to look after their own health. And in terms of legal rights, we know that globally women have less rights, for example, to be able to divorce, to be able to inherit. And again, this can all impact on their ability to look after themselves and make healthy choices. And one of the other things that is important to think about is violence against women. And we know that this is a public health epidemic. We know that from some global studies that 1 in 3 women have experienced sexual or physical violence from their partners. And in some settings, for example, 45% of adolescent girls report that their first sexual experience was forced. And we know that partner violence has a huge impact on health in many different ways. And when we look specifically at STIs and HIV, we know that if someone has experienced partner violence, they're more likely to get HIV and other STIs, so by 1.5 times. And that's not just due to sexual violence, it can be due to emotional violence as well. And it can be due not just to being in a currently abusive relationship, but being one previously. So for example, if a woman is in an abusive relationship and they may not be able to decide when they're having sex or who to have sex with, or whether they can use condoms, for example. And if someone has experienced violence in the past, it may impact on their self-esteem, may lead to increased risk of alcohol abuse, for example, and this may all impact again on their ability to practice safe sex. So there's a real link between HIV and violence against women. And we actually did a study in East London about 10 years ago now, where we surveyed all the women attending our HIV clinic at the Homerton in Hackney. And we found that 52% of women who were attending our clinic had experienced partner violence in the past, which is huge. And a global study of women living with HIV found that up to 89% of them had experienced partner violence. So there's massive links. And experiencing current violence can also impact on their ability to engage in HIV care. So it can impact on being able to take medication, go to clinic, can impact on their ability to share their status. So you probably wouldn't want to tell your partner you had HIV if you're worried that you were going to experience violence from them. So as healthcare clinicians, particularly, we try to tell people to tell their partners about their HIV, but it's important that we consider if it's safe for them to do so. And And it's not just partner violence that's an issue, there's also institutional violence. So we know, for example, that involuntary and coerced sterilisation and forced abortion has been reported amongst women living with HIV in at least 14 countries worldwide. So it's not just about partner violence. And of course, women are different, and it's really important to take an intersectional approach. So I'm just going to use two examples of that. So first of all, talking about racial inequalities. So as I said, 80% of women living with HIV in the UK are from ethnic minority groups, predominantly Black African. And when it comes to late diagnosis, I said it was 50% of women being diagnosed late, but if we look at the ethnic breakdown, actually it's higher amongst Black Caribbean and Black African women than it is amongst white women. And in the US, HIV prevalence in trans women is 14%, but again, looking at it by ethnicity, it's 44% of African American trans women have HIV, 26% of Hispanic trans women, and 7% of white women. And this is a study we did looking at socioeconomic status and mental health amongst older women living with HIV in the UK. And what we found was that Black women were more likely to have a university degree, so much more likely to be highly educated than other women, but more likely to be unemployed. They were less likely to have enough money for their basic needs, and they were more likely to report severe psychological distress, but less likely to be on antidepressants, so barriers to mental health care. So it's really important that we don't think of women as a whole, we take an intersectional approach and think about all the different parts of their social identity, which may impact on their health and well-being. The other group I wanted to talk about as an example today are trans women, non-binary and gender diverse people in terms of HIV. So they're twice as likely to be diagnosed late with HIV in the UK. And we know that there are increased risk of HIV infection due to social stresses and structural inequalities. And for example, 2 in 5 trans people have experienced a hate crime because of their gender identity. More than a quarter of trans people in a relationship have faced partner violence. 1 in 4 have experienced homelessness. And we know that social vulnerability and transphobia can impact on mental health, manifesting in alcohol and substance misuse and an increased risk of mental health problems like depression, anxiety, and suicidal ideation. And there's also a higher prevalence of history of sex work in trans women than in other groups. So all these things together can increase the risk of HIV. And there was a big survey done about 5 years ago asking people living with HIV about stigma, and it found that the trans people that they interviewed in this showed concerns about being treated differently by healthcare providers across a range of settings, so worries about transphobia, and with many of them avoiding healthcare as a result. However, the good news is we know that from data that their uptake of taking medications and being undetectable was the same as everyone else. But again, there's still a real lack of data on this specific group. So what about lesbians, and in terms of the chance of passing on HIV through sex? So just to say again, there's not much data on this, and I think it's going to be a theme possibly certainly running through this presentation, and possibly Selena's as well. There's a lack of data. What we know is that the risk of female to female sexual transmission is extremely rare, with only a handful of reported cases. But obviously women can get HIV in different ways, so through other means such as injecting drugs or with sex with men. And it is possible, although the risk is low, if through the sharing of sex toys and exposure to blood during sex. So making sure that sex toys are clean is really important, but generally the risk is low. The risk more comes from having sex with men or injecting drugs. And it's really much easier to prevent HIV than it ever has been in the past. And we've got lots of ways to do that. So we know that if you test regularly, that's a good thing, because if you're testing, you're knowing your HIV status, and if you are positive, then we can get you on treatment, get you undetectable very soon, so you won't pass HIV on. There's obviously condoms as well, and also this new thing called PrEP, which is a tablet that you can take to prevent you getting HIV. And this is a tablet, but in the future, we're hoping it's going to come in injection form as well, like getting the depot injection for contraception. So you can have that once a month and you don't need to think about it. And PrEP, I think, has mainly been advertised for men, but actually, obviously, women can get it as well. Anyone who's at risk of getting HIV can have PrEP. And it's worthwhile chatting to your sexual health clinic because it's a really effective way, and it puts the onus in our hands. We don't have to worry about condoms, etc. We know that we're protecting ourselves from HIV, a bit like the contraceptive pill in that way. So what about HIV in South Asian? So thinking about another intersection here, and I'm almost done, I would realise I might be going over time. So actually South and Southeast Asia have had the largest HIV burden beyond sub-Saharan Africa. So in terms of how common it is, it's the second highest region. And there's estimated to be about 3.5 million people living with HIV in this region, of which 2.1 million live in India. And in the UK, there's not that many. So compared to other ethnicities, it's small. And again, the visibility of Asians is small in the HIV world here. So in 2017, there's about 3,500 people, of which just over 1,000 were women. So only 3.8% of everyone seen in the UK for HIV care nationally. And as I said, following on from the conference from 2018, it got me thinking a bit about, what is the data regarding South Asians and HIV? And we did a little literature review, and we found actually the last study looking at this population was back in 2004. So it's a really under-researched area. So we did a very simple study where we just looked at the case notes of all the people who were identified as being Asian attending our HIV clinics in East London. So just 131 people. And what we did find out was that it was more likely that women and heterosexual men were more likely to be diagnosed late than men who have sex with men. So there's a real need to get people thinking about HIV more and testing more. And more women and heterosexual men were likely to be tested due to having symptoms or being unwell, rather than going for routine screens in sexual health or getting check-up with their GP or elsewhere. And what about, so in terms of today's presentation, what about lesbian and bisexual women? So this was this big, I'm sure you've all seen it, this big Bollywood film. I was lucky to see it at my local cinema, which was released a couple of years ago, which is the first Bollywood film which had a lesbian couple in it. And I was really, when I was searching for the images, I realized actually the main poster doesn't have the couple in it. It's just the main character's family, but without her partner, which I actually find incredible. So that's a woman at the front, but not her partner. And really, the reason I'm putting this up is there's a real lack of data. There's no specific data looking specifically at South Asian lesbian and bisexual women or transgender women. And again, that's something we need to look at. There's a big data gap there. So in conclusion, women make up over half of people living with HIV globally, and they face specific barriers to accessing and engaging in care and taking medication. They're underrepresented in research, policy, and health promotion. And as I said, it's really important to take an intersectional approach, so thinking about different groups of women. We need to do more work to really understand what women who are living with HIV or those affected by HIV, what their needs are and what we can do to support them better. So I'm going to end here. Here's my Twitter and my email if anyone wants to get in touch, and I look forward to the next talks in the panel. And these are just some beautiful coronavirus Indian goddesses I found. So I really love this image. So I'm going to stop sharing my screen now, and thank you very much for listening.
Thank you so much, Dr. Gayatri, for that illuminating presentation. I think especially around the data, being able to demystify what was already there and then what's absent. It's really, really fascinating for me. And now it's time to invite Dr. Selena Singh to present.
Thank you very much. Sorry, I was just trying to come off mute there. I'm just going to share my screen. Hopefully this works. Great. So thank you very much for the introductions earlier and for inviting me to present. So I'm going to talk to you a little bit about sexual health for LBT women. And for the context of this talk, I'm talking about cisgender, lesbian and bisexual women and trans women of any orientation. Just a bit about me and where I work. So like Dr. Gayatri, I work in East London. The clinic that we work in is called All East. It's based in a couple of sites across East London. So there's our logo at the top that's flashing. The bottom left photo shows what our waiting room looked like pre-COVID. So it's obviously a lot more spaced out now. We've got a lot less chairs in there. And I work predominantly in the London Borough of Newham, which is, it's actually not my team shown holding the rainbow flag. So this is workers from the actual London Borough of Newham. So Newham was the first London borough that celebrated, that flew the rainbow flag for LGBT History Month, and that was back in 2019. It's I'm flagging it up because it's one of the most diverse areas in England. Despite that diversity, it's still really sad that we don't see as many people of colour, particularly from lesbian, bisexual groups, in our clinics. And as Rogeshri said, there's a real lack of data. But we are an incredibly diverse area, and it's a fantastic place to work. So if we think about what sexual health is, a lot of people will think it's just about infections and getting tested for infections and being diagnosed and treated for them. It's not. There's loads of other things that encompass sexual health. So in a clinic like I work in, we would look at other conditions that affect the genitals. That might be skin problems. It might be other things that can cause changes in discharge, which aren't sexually transmitted infections. We also deal with things like contraception. And contraception is not just about preventing pregnancy, and I'm going to talk about that more in a bit. We also want to make sure that people are having enjoyable sex and removing any barriers to having enjoyable sex. So that may be that people need help with risk reduction or prevention of certain things. It may be that people need help with management of things like psychosexual issues. So perhaps sex is painful, perhaps sex is difficult for lots of reasons. And we look after people to ensure that they're having the kind of sex that they want to. There is an overlap with things like gynecology, because when you get a symptom down below, you may not always know what's causing it. So we often end up seeing gynecological conditions, and we've got referral pathways and things like that. And there's a lot of screening and prevention as well. So things like cervical screening tests, vaccinations, things like that. And because we know that, as Rogeshri just said, there's a huge overlap between things like domestic violence, things like emotional problems, drugs, alcohol, in patients who access sexual health care, we're quite proactive in screening for these problems and being able to offer support. So it's very much not just about infections. So for those of you who might not be familiar with clinics, or perhaps have never been to a clinic, sexual health clinics are all free, and that includes if you need a prescription. There's not a prescription charge to pay, everything is free. They're open access, which means that you don't need a referral from your GP or from anybody else. You choose a clinic and you go. They're confidential, and that means that we have separate records from other services. You don't have to use your real name if you don't want to. Nobody's going to ask you for ID or anything like that. And we don't share your information or the fact that you've been to a clinic with anybody else, unless in very, very specific circumstances where we're worried about somebody's safety or safeguarding, or perhaps where there's been a disclosure of a crime happening, but that's incredibly rare. In the main, nobody would know about your attendance, including your family or your GP, and it's not linked to your NHS number, so no other NHS service would know. And there's really a huge variety of services and different ways of access, and I'll talk a little bit more about that in a second. So it may be that your local clinic doesn't suit your needs. There may be other ones that you can access, and that's absolutely fine. You don't have to go to the one that may be down the road from where you live. But we do know that it's not easy for everybody to attend a sexual health clinic. So the act of going there is identifying. They can be really busy. So pre-COVID, we would see 100, 120 people in a day. For some people, that's really daunting to walk into a service that's busy. It can be really difficult to know if you're in the right place. Should you be going there? Is it for you? And that fear and that uncertainty will often stop people from coming to see us. It can also be really difficult to know what's going to happen. So, you know, if you've never had an experience of this before, you might think, well, what kind of questions am I going to be asked? Or what am I going to have to do? Am I going to have to take all my clothes off? I don't really understand. And we know that lots of LBT women have had difficulties accessing healthcare and problems in the past, and that can often put a lot of fear about what could happen in the future based on previous bad experiences. So if we think a little bit about the issues with access to healthcare, so there was a survey done by the UK Government Equalities Office back in 2017, and this looked at healthcare access amongst lesbian and bisexual women. So this report found that bisexual women who tried to access or did actually access sexual health services were twice as likely to report they were unsuccessful compared to lesbian women. But actually it was different among trans women. So among trans women, bisexual women reported it was easier to access sexual health services than lesbian women. And another really important finding from this survey was that there was a huge regional variation in ease of access and use of sexual health services. So places like Northern Ireland were significantly worse compared to places like London. And that, I think, is true for the wider society as well. The sexual health services in Northern Ireland are incredibly difficult to access and can be quite stigmatising. There was also some themes that they looked at, and this was not just accessing sexual healthcare, but also general healthcare. And these were some of the issues that women had reported. So they'd reported that there was often an assumption of heterosexuality, and then it was very difficult for them to have to kind of come out to the practitioner. They found that really awkward. They didn't like to have to do that. There was a huge fear of judgment. There was a fear of, or there were experiences of homo, bi, or trans phobia, difficulties in having a same-sex partner acknowledged, so perhaps thinking about being admitted to hospital and wanting your same-sex partner to be put down as your next of kin, and people going, well, that's not your partner, that's your friend, things like that, and then having to sort of fight to get your partner acknowledged, just the things that people flagged up as issues. And a lot of women found that there was a real lack of appropriate knowledge or advice, either based on their sexual orientation or their gender identity. So they would go to see a clinician and disclose issues, and the clinician wouldn't know what to do because they hadn't come across somebody of that sexual orientation or gender identity before. There was also another really interesting survey done, and this was back in 2008, and this was done by Stonewall. So this was a survey that identified just over 6,000 lesbian and bisexual women. And one of the things that, it was sort of looking at women's health in general, but one of the things they particularly looked at was sexual health. So less than half of these women had ever been tested for STIs. But of those who were tested, half of them were diagnosed with an STI. So that's really quite high. And of those with an STI, a quarter had only had sex with women in the last 5 years. So quite a lot of women were having sex with women and men. Looking at the people who weren't tested, about 3/4 of those thought they didn't need to test because there wasn't a risk from sex with women. And 4% of people were actually told by a healthcare professional that they didn't need to test, which is completely wrong. So if we think about STIs in LBT women, STIs can be passed on between women, and they can be passed on through genital to genital contact. And that can just be rubbing together, there can be scissoring, things like that. Oral sex is also a way of transmission of STIs, and anything that causes genital fluids to be shared. So that can sometimes be or toys. And from that Stonewall survey, there was an interesting quote from a lady that I'm just going to read to you. So Sahima said, "I'm appalled at how little sexual healthcare advice and support there is for lesbians. I recently had a check and had no idea I could contract so many infections through lesbian sex. There is little education and support for lesbians." And I think that's probably quite a common experience for lots of women. So we've talked a little bit about STIs. So what are the common STIs that you may have heard of? If we divide them into separate groups, so you've got bacterial STIs, things like chlamydia, gonorrhea, and syphilis. There are viral STIs. This would be commonly things like herpes, genital warts, which is caused by the human papyrus or HPV. As Dr. Rakesh talked about, HIV and things like hepatitis B and C. There's a protozoal infection, so a little parasitic infection called Trichomonas vaginalis. And then there are other things that are what we call, not strictly speaking, sexually transmitted infections, but they are sexually facilitated. So they can be passed between sexual partners, again, with sharing of fluids or sharing of toys and things like that, but they're not strictly speaking STIs. And to a certain degree, all of these STIs could affect LBT women. And a lot of the risk of different types of infections or different transmissions depends on the type of sex that you're having. But all of these would be pertinent to this group. I said I'd talk a little bit about something called bacterial vaginosis, which you may or may not have heard of. So this is a really common cause, probably the most common cause, that women report a change in their vaginal discharge. So it typically causes your discharge to go quite runny, and it can be kind of grey or white in colour. And the most characteristic symptom that people report is a change in odour, and people typically describe this as fishy. It's less common to get things like itching. And this is caused by alterations in the bacterial flora. So Rakesh mentioned a little bit about the microbiome. So in different parts of our body, we have bacterial balances. So in the mouth, in the intestines, and in the vagina, we have a bacterial makeup, which is unique to all of us. And what should happen is that kind of looks after itself. You've got a mixture of, in inverted commas, good and bad bacteria, and they should be living in happy harmony. What happens in bacterial vaginosis is you get an increased amount of the bad bacteria that take over, and they cause this alteration in the microbiome, which causes the symptoms that are listed. Why am I talking about this? Well, because some studies have shown that there is a higher prevalence in lesbian and bisexual women, and that could be for lots of different reasons. But it's important to know that it is a treatable condition, so it's treatable with antibiotics, and there are also some non-antibiotic treatments as well. But it can be a problem that is recurrent or persistent, and it's really important to know that there is help available. So if anybody is suffering with this sort of thing, please do seek advice from your GP or from your sexual health clinic. And I mentioned that we deal with sexual problems, and these are incredibly common. So it might be things like loss of libido. It might be things like difficulty reaching orgasm, and that's actually more common in heterosexual women than in lesbian and bisexual women. There can also be conditions that cause pain with sex. So that can be pain on penetration, and not just penetration with the penis, but also with toys or fingers. Sometimes that's caused by simple things like lack of lubrication, but sometimes it's caused by a condition called vaginismus. So vaginismus is a condition where the muscles, the pelvic floor muscles and the muscles of the vagina go into an involuntary spasm. So there's an attempt at penetration and the vaginal muscles just sort of almost freeze or clamp up, and penetration is difficult, often painful, sometimes impossible. This is a completely involuntary condition. So the woman can be lying there thinking, well, I want to do this, I'm feeling up for it, I'm in the mood, and the body's just saying, no, it's not happening. Again, there is treatment, there is help for this, but it's really important to know that it is an issue, because if you're not aware that this is a problem, you might think, well, there's something wrong with me, there's something wrong with my body, I'm not shaped the right way, something's not right. There are also conditions that cause pain in the vulva. So there's something called vulvodynia, which is not particularly well understood, but we think it's a condition where the nerves almost become hyperstimulated, and you start feeling sensations when the nerves aren't actually being touched. So people will describe this as a burning sensation or shooting pains or stinging. And again, there's treatment available for that, but it's important to identify that it's an issue so that we can help you with that. So what should you do? So we recommend testing for STIs to everybody, even if nothing feels wrong. And we particularly say that you should seek help if you have symptoms, and I've listed some of these below, so particularly an unusual smell, a change in your discharge, if you're feeling itchy or you've got a rash, there's lumps and bumps, you get pain in your tummy, pain in your vagina, pain during sex like we just talked about, or perhaps a change in your bleeding pattern, so the bleeding becomes abnormal, perhaps bleeding after between periods or bleeding after sex. And we're talking about getting tested, it doesn't just mean coming to a clinic. So there is an increasing, particularly since COVID hit, there is an increasing focus on being able to test yourself without having to go into a clinic. And this is really most appropriate if nothing is wrong and you just think, well, it's time for me to get tested, or I'm thinking about having sex with somebody new, let me just get a clean bill of health. This is mostly done by self-testing. So obviously there's no examination. You go onto a website you order sent to your house free of charge, and you do the samples yourself. And the tests that they send will really depend on the sort of sex that you're having. So when you order your test kit, they'll ask you some basic questions about what sort of sex you have. And then they will send you probably a vaginal swab, maybe a throat swab, maybe an anal swab, depending on what answers you give to those questions. And they also send you a little blood bottle to take a sample of blood, and they send you a finger prick, a bit similar to how people test their blood for diabetes. And you just prick your finger and fill up the little bottle with blood. It all comes pre-packaged, so you put it all back in the packaging, and it's all free post, send it back to them. So some examples of providers that offer this. So obviously in London, we're lucky to have something called Sexual Health London, which covers the vast majority of London boroughs, all free of charge. In other areas of the country, there are providers like SH24, but it really depends on where you live, because each local authority will have a different agreement. So sometimes you have to do a bit of Googling, but this is all free, it's all very discreet, and you don't have to use your real name, you don't have to use your real address. If you're worried about having this sent to your house, you can have it sent to a friend's house, but I will say that they are excellent, and they've really worked on getting discreet packaging, so it doesn't look like you've ordered anything particular, it just looks like you've ordered something off the internet. It comes in a plain box, there's nothing identifying about it, so they're really useful in that respect. If something is wrong, then it would be better to be seen in a clinic. So most sexual health services will have a website. Again, just sort of search what's in your local area, but as I said, if you don't feel comfortable going to your local clinic, perhaps because you're worried about who might see you, or perhaps because you know somebody who works there. You don't have to go to your local service. Most clinics are doing telephone triage at the moment because of COVID. So previously we used to have what we call a walk-in service, where you just sort of turn up, put your name down, get a slot later for the day and be seen. At the moment you book an appointment and have a telephone consultation, and then a nurse or doctor would advise you what you needed to do. And then based on that, you might be asked to come to clinic, or you might be asked to do some tests online, or you might be sent some treatment in the post. If you were to come to the clinic, you might need an examination. And it's important to know that you can request a gender practitioner if that makes you more comfortable. You can request a chaperone. We should be offering chaperones, particularly if you're being examined by a male practitioner. And everything is on your terms. You don't, if something feels uncomfortable, you can ask people to stop. And you don't always need a speculum examination. So for those who are not familiar, a speculum is a little plastic tube that goes into the vagina, also sometimes called the clamp. It can feel quite uncomfortable. It doesn't always need to be done, or if that's something you're particularly nervous about, you can talk to your clinician and see if there are ways around this, or see if we can use the smallest size to make it a bit more comfortable for you. So if we think a little bit about who gets infections, so we're really lucky that we have amazing data from Public Health England. So just like with coronavirus, we submit data about sexual health and diagnoses and diagnoses of STIs to Public Health England, and they create amazing, really rich data sets for us. So every single year when they release the data, the STI diagnoses are always highest in young people between the ages of 15 to 24, Black and ethnic minority groups, and gay and bisexual men. However, so the data from 2019 showed that the largest proportional increase in all new STI diagnoses was in people of Asian ethnicity. And this is the first time this has been seen. So that was a 16% increase overall, primarily for gonorrhea, which on its own was a 36% increase, and chlamydia, which is a 27% increase. So those are quite big jumps. Now, we don't have a breakdown whether this is male or female, sexual orientation, anything like that. We just have a very bland statement which has been given there. So it'd be really interesting to get a little bit more data on this and sort of drill down into exactly what's happening to show this this jump. But I thought for this talk, that's actually really, really interesting, really important information to get out there. So how can you prevent this? How can you look after your sexual health? So barrier methods are still important. So we have both male and female condoms. A female condom is probably less known about. It's shown in the bottom right picture. It's a bit like people describe it sometimes as a plastic bag, but essentially it's a tube that you can insert inside the vagina. So you can use this with things like sex toys. And if each woman has a female condom in, then you don't have to then wash sex toys in between using them. You can also use male condoms on toys, or if you're having sex with a man. You can use things like dental dams for oral sex, but you actually don't have to get specific dental dams. You can cut off a condom, so cut off the tip, cut up one side, unroll it, and then it's just a sheet of latex, which is essentially what a dental dam is. Some people will choose to wear gloves for fingering or for fisting, and it's really important to use lubricant with that as well, because they can be quite dry. As Rageshri said, it's important when we're using sex toys that we keep them clean, so you should wash them or try and use a barrier between partners and also afterwards. She mentioned PrEP, and that's a really important prevention tool for HIV. And there's things like vaccination as well against hepatitis B, and that will really depend on the type of sex that you're having as to whether that will be important. But testing is always key. So we can't stop the chain of infection unless we know who's got infection. So it's important to get checked out for that. So I mentioned that we also look after things like contraception. So contraception is not just about pregnancy prevention. I know the conversations can sometimes be very heteronormative around this. Often when lesbian or bisexual women present to services, they're almost sort of told off for not being on contraception. But there are some roles for contraception which aren't just about prevention of pregnancy. So it can be used to help with things like period pain, also things like endometriosis and heavy bleeding. So if those things are problems, we may talk about using contraception to help to control them. It's also important to look after other bits of health, so things like cervical screening or smear tests. So in that Stonewall study from 2008, it said that 15% of lesbian and bisexual women had never had a smear, compared to 7% of the general population. It is recommended for anyone with a cervix between the ages of 25 and 64. And it's a common misconception that you need to be having penis and vagina sex to be at risk. Actually, that's not true. Everybody can be at risk. HPV can still be passed on between women. And smear tests are not going to be around forever. So what actually happens now when you have your test is it's tested for a virus called HPV, or human papillomavirus. If that virus isn't there, they actually don't look at the smear test anymore. So in the future, we're going to be moving to self-sampling, so taking your own swab from the vagina to test for that virus in the first instance. And then if the virus is found, you would then be called to have a smear test. So actually, a lot of women wouldn't need the full smear test and would be able to do a much simpler test by themselves, usually in the privacy of their own home. So again, some comments from the Stonewall survey. So one woman said, I had cervical cancer and surgery and radiotherapy. It was detected in a routine smear test and was already advanced. A lot of lesbians think they don't need to smear test because they're gay. And another woman said, I was treated for cervical cancer after receiving a positive smear. I was originally told I didn't need a smear as I never had sex with men. So again, just really important that we change the conversations. So what else? So I said, you know, we also do this other screening. So we would ask about things like smoking, alcohol, drugs, and domestic violence. I'm not going to talk about domestic violence because Rageshri's touched on it already, but we know that 2/3 of lesbian and bisexual women have smoked compared to half of women in general. We know that 9 in 10 lesbian and bisexual women drink, and 40% drink 3 times a week compared to a quarter of women in general. And lesbian and bisexual women are 5 times more likely to have taken drugs. And this was from that 2017 survey done by the UK government. Mental health problems are also huge among this group. So among cisgender women, 28% of lesbian and 39% of bisexual women have accessed mental health services. And among transgender respondents, lesbian and bisexual women were equally likely to have accessed mental health services. And we know that within this group, there are much higher rates of deliberate self-harm, eating disorders, and suicide attempts. And we also know that these things are really, really common in South Asian communities, and really particularly in women. So this is definitely a real issue. So what can be done? What's happening at the moment? So we talked about the difficulties in accessing service, and we talked about the things that have happened to people in the past. So there is a real push towards making services much more accessible. So this is something called the Rainbow Badge, the NHS Rainbow Badge, and there's also a rainbow lanyard that you can see in the bottom picture. If people wear this, if clinicians are wearing this, services wearing this, this means that service is open, non-judgmental and inclusive. It's not just a sexual health initiative. Lots of doctors, GPs, hospitals, departments are committing to this scheme, with the understanding that we need to be really open and inclusive to everybody, and it needs to be really important for everyone to feel safe and able to access healthcare, whatever they're accessing it for. And so this is becoming really, really popular. It launched a couple of years ago, and it's really something that's taken off in a great way. So just to wrap up, so sexual health issues affect everyone, including LBT women, regardless of ethnicity. But despite that, we still see much lower attendances at clinics. And as Rageshri said, there's a huge lack of data. We're not really sure why this is. Is it fear? Is it stigma? Is it the perception of not being at risk? And we know that stigma is a huge issue, but it's really, really important to know that help is available and that healthcare services are definitely focusing on being more inclusive. And we need to bridge that gap. We need more data. We need more work to be able to identify what's happening, and particularly in South Asian women. And I want to leave you with this final slide. So this is a work of art called The Great Wall of Vagina, done by a British artist called Jamie McCartney. This is actually only a snapshot. There's actually much more of it. There were 400 of these plaster casts of women's vulvas. And it's just to say that we are all different, but we are all normal. There's a huge variation of what's normal out there, but everybody is normal. Thank you very much.
A brilliant note to end on. I think many people should check out the artwork in full. Now would love to hear from Neelam Hira, and the presentation will be shared by Siddhi.
Hello, everybody. Just as we wait for Siddhi to share that presentation, because as always, somebody's going to have technical difficulties, and it's going to be me. So I hope you've all got your tea ready, because I'm ready to spill it with you. So who am I, and what role do I play? Because I'm not somebody with a medical background. I'm not like my esteemed colleagues here. So who I am, I'm Neelam. I'm the founder of an organisation called Sisters, which was set off the back of my journey around reproductive and mental health issues. I've got PCOS and endometriosis, and I really felt around these conversations, there was a lot of stigma attached to it. The way that I was treated by healthcare professionals, there was a lot of medical gaslighting and biases from being a South Asian woman. And I thought, I can't be the only person that's going through this, and I'm going mad. And turns out that I'm not the only person, sadly. So I set up Sisters in 2015, so nearly 5 years ago, 6 years ago. And the support for us, as well as the patients that got involved, has been amazing. But what it really showed was there was a need for this inclusive space. We were originally just, for a South Asian community, because that's all I knew. But as we've grown and more people have got involved, we've got a really intersectional and inclusive lens, and it's really important for us to remain that way. Because I always felt I didn't have a seat at the table. I didn't have a voice as a patient. I always felt that conversations were had about me, but without me. And now I'm using a lot of quotes here, but now I kind of feel that we've become the face of the race. And it's almost an element of tokenism for having ethnic minorities at the forefront of some of these conversations. But as we can see from my colleagues before, there's not much data to back this up. So, Sydney, if we can move to the next slide. So let me just explain what we've done within these spaces. So our initial thought was around peer support. Our Sisters mission and tagline is taking up space together, because patient-centered conversations need to be happening together. So rather than my colleagues in the NHS working in one sphere and then you've got the patients in another sphere, I want to bring everybody on that journey together to make those services more inclusive and more patient-focused, to create an outcome that works for everybody, and hopefully less of a delay and a burden on the NHS. So we created safe spaces for these conversations, and more often than not, as we all know, there's no space for people of colour within the LGBT community because of the cultural faith-based barriers. And we've worked with a number of organisations to facilitate these safe spaces and collaborate, because we're not the experts, I'm not the experts, it's all a patient-centred approach. It's all about the people within Sisters. It's what they want and what, their needs. And inclusion, it's so important. So when we originally registered at Charities Commission a few years ago, we were called Sisters, Women Support and Awareness Group. And as Sisters grew, and as I grew, challenged my own biases, managed my own level of unlearning, I realized that we have people within the group that are non-binary, that are transgender, who still suffer with reproductive health issues such as endometriosis, PCOS, etc. And then I was effectively erasing their experiences by this word. So we changed it. It was really that simple for us. And within that space now, we've got more of a representative membership of these communities as well, because there is a space for them at the table. Their voices are recognised, and they are there, and their existence is not to be debated by anybody. So we really want to recognise those voices and make sure they're centre of those conversations as well. So the other thing we do is a sort of education. So what we do is all the amazing work that my two colleagues have been speaking about, we want to try and filter that through to a grassroots community. So due to their amazing work, we're able to sort of capture that and put it through into the community. What we do find difficult is we do work with the refugee communities that don't have English as a first language. And I mentioned they don't recognise fertility issues. And one of the reasons I mentioned that in particular is most people tend to find out about their reproductive health issues during the fertility stage, or they find out the medical biases around the fertility aspect. So I really wanted to highlight that fertility is still put on a very big pedestal within the NHS as well. So taking PCOS for an example, most GPs will still tell patients about the fertility implications of having PCOS, but will not speak to them about all the other implications like cardiovascular disease, fatty liver disease, which are actually more prominent and also more prominent in people of colour. So these are really big things that I think we need to be talking to the communities about. So that education piece is really important for us. And really, we just want to outreach as much as we can. We want to work with other organizations. You know, we're a sisterhood for a reason. We'll join hands with anybody because we want to create inclusive and safe spaces for everyone. And we recognize, I'm not going to be the face of the race. I don't want to be. I want the patients to be the center of this conversation, not me on my journey. So just a disclaimer before we go on to some of this, this presentation was put together by people within Sisters who identify as LGBT. The reason I'm talking today is I'm going to talk on their behalf because they don't want their journeys to be shared with their real names and stories, because they're still going through that sort of shame and stigma attached to being a person of colour and within a faith setting as well as the double discrimination around how they're treated within the healthcare system and general institutions. So I really wanted to put that out there, that I am their voice today, and I'm hoping in years to come that they will be the voice, they will be the next advocates, because it's so important for their voices to be heard. So Cynthia, we move to the next slide. So intersection and reproductive health, I've just mentioned some of these points briefly. There's a real need to recognise intersectionality and double discrimination faced by patients. So as I've just experienced and said, as a South Asian woman of colour, you're up against different barriers, but then you've got other barriers being a woman of colour having a reproductive health issue. And I'll come more onto that later. You'll see through some of the examples I'm going to show from these three particular sisters of ours, their particular journey, and you'll see that firsthand. We need to recognise there is cultural barriers, and that includes faith as well, which people really find difficult to navigate, not just themselves, but the community acceptance around them, because that has a massive mental health issue for a lot of these people who are trying to gain that level of acceptance and not finding it. Fertility in IVF, it's a conversation that comes up quite often within Sisters, and it's widely reported that those from BME backgrounds are also likely to be from low socioeconomic backgrounds. So it makes the journey around IVF more difficult already if you're a person of colour living in this low socioeconomic background and not actually having the same education, access to equal healthcare when going through the IVF journey. And that's something that we're noticing with one of our couples within Sisters in particular. Something the team wanted to highlight was imagery. So often they find that imagery is around conversations about reproductive health, around conversations about health generally, is very heterosexual. It reinforces the message that they can't be what they can't see, and it suggests that the people of colour don't really need that support if they're struggling because they're not represented. But in conversely, they've also said that they always get people in touch with them, and I can tell you from Sisters' perspective, we always get people in touch with us when it comes to places like Black History Month, etc. So there's a level of tokenism as well. So it's almost that double-edged sword. Do I be the token to support the community, or do I just not be included and then never have a face? And it's really difficult for these communities. There are stereotypes that erase significant experience of marginalised groups. So one of them is something that keeps coming up a lot in Sisters is people of colour are seen as hyperfertile. They're seen as having big Asian families and, you know, having lots of children. And when they're not that person, it's a very difficult then conversation, not within just the family sphere, but within the NHS as well. And I'll move on to some of those conversations shortly. Sydney, can we move on? Sydney's brilliant at this, isn't she? I could have done this. So just a couple of myths and microaggressions, and I know my colleagues have spoken about this earlier. Myths around lesbian women not needing access to care or cervical screening, and it also extends to other issues like STIs. This is still a thing, and I remember speaking at this event a couple of years ago, and it was a thing then, and it's still a thing now. I'm not too sure what we should be doing around this. I know that having inclusive conversations at really grassroots community levels would make such a difference to this. But yeah, we need to change this, because it's just so concerning from me when almost like patient to patient, peer group to peer group, we're still telling people, no, you still need to have your cervical screening, or have you had it? Why haven't you had it? So what we really want to do is is challenge that and empower individuals within the community so they can be the voice within the communities, because it's something's not working. We had a few issues around, no, I wouldn't say issues, but we had a few questions around, there's this idea if somebody is trans and they've lived with endometriosis or PCOS or any other health issue, that their health issue goes away and then the focus is their transgender identity, but the health issue still remains. For example, endometriosis doesn't leave your body. So regardless of whether you're transgender, it's still there and it's still something that encompasses the person. And I think we need to stop focusing on one issue. We need to focus on the person holistically as well. And a couple of examples of microaggressions that have been shared, and this isn't just within the healthcare professionals, it's generally just discrimination as a general, is when a person of colour presents themselves as queer, they get asked if they're actually queer. Like, this is a normal question. It's not a normal question to be asking anybody. We wouldn't ask someone, are you actually straight? So we shouldn't be asking people if they're actually queer. It's not a normal thing. There's suddenly an influx of questions and stereotypes that if a person of colour presents themselves as LGBT, then the family must be homophobic, right? Because this is just what people of colour do. So these sort of questions are quite often targeted at people of colour, and these are the barriers that sort of hinder some of these conversations, really. So I wanted to highlight that as much as we may think, and this may be an echo chamber for us because we may not think like this, it is still happening on the ground, and that's what we need to really focus on. Can I move on to the next one, Siddhi? So I'm hoping you can all read this on your screen, but I'm just going to go through it with you in brief. So patient A is married to a British citizen. Before getting her permanent residency, she had to prove her LGBT status with her partner. She was asked during an interview with immigration whether the couple wanted children. She had said yes. And then she was asked how and who would carry, and lots of other very intimate, personal questions which shouldn't have been asked of her. So from this experience alone in coming into the UK to be with her partner, there's already a distrust with the government and government-related institutions. So there's already a problem there. She finally got the grant of her visa. The couple were looking for support around fertility. And when speaking to healthcare professionals, it was just assumed that the British partner would carry the child, because why would the Indian partner carry the child? And the healthcare professional wasn't sure if someone from abroad would carry because of the cultural heritage. And these are some of the conversations that are still being had today. Both of the couple have reproductive health issues, having PCOS and the other having endometriosis. And the patient was also asked if she'd be having treatment here or in her home country, despite the fact she's actually a resident in the UK. So that's one example. Could we move on to the next one, Siddhi? Patient B is a resident in Handsworth, Birmingham. She was happy with me sharing that much detail. She's lived there all her life, the family have all migrated to the area, they've all lived there, grandparents, aunties, uncles, etc., sort of all in the same area. So she has PCOS, and she's been pressured for some months to find a husband, and has been suicidal for some months because of her hidden sexuality, diagnosis of PCOS. However, when speaking to her male GP, who is also a family friend and has been a GP for the whole family, he's mentioned in passing the need for the patient to take the contraceptive pill to manage the PCOS. And how's it going? It was from what I gather, it's a very offhand comment to another family member, which has sort of been blown out of proportion. It's resulted in the family believing that she's actually sexually promiscuous, and she's been forced to leave the home during the pandemic. We've managed to get support for her, but it just shows the importance of that patient confidentiality. And I really wanted to labour the point around cultural priorities overtaking confidentiality, because it does happen. Can we move on to the next? Again, another resident in Birmingham from an East African background, diagnosis of fibroids, suffering with heavy periods. She's come out to her family due to an external incident where somebody had found out. her mother said that the reason she suffers with heavy bleeding because of the fibroids is due to her sexuality, and she's allowed others to mess with her. And she's undergoing support and counselling for this. Her GP said that the heavy bleeding could be related to FGM, and it's not. There was no conversation about actually sending this person for any blood analysis or anything. It was just assumed. So another direct of double discrimination. If we move on to the next. So there's a couple of questions I wanted everyone to think about. So what are the obstacles within the community? And we can see why, from the stories above, where these obstacles are coming from, and why there's a lack of South Asian women in the sort of these campaigns. We can see from the above examples why we've got that. And also, this is something that I'm quite passionate about. I did my TEDx talk in this. It's the virginity myth. It really perpetuates heteronormative sex, and by defining virginity as a loss of the hymen due to penis and vagina sex, it basically negates some experiences of sex. So lesbians, for example, if they're sexually active, are incapable of losing that virginity. It erases any sexual contact, and that doesn't involve the penis and vagina, and it becomes almost foreplay and nothing more. So I think this is really important that we recognize these conversations and how these myths perpetuate these stories even more. So I really believe the support groups that are out there, the community-led ones, and they're led by people of colour in these spaces, are really important because it provides that safe space to be heard and seen, and it's so important for them to have a voice. So what can we do better? Centre the patient voice into the conversation by the actual patients themselves, because too much we talk about them without them, and I really think that really needs to change. Creating safe spaces, building trust within communities will create better relationships between healthcare professionals and the patients. Patient confidentiality is absolutely key, and I know that everyone's touched on it beforehand, but we still see small examples of this. And visibility, not just tokenism. We want to see actual real change here. So they're real snippets from a grassroots community and what we can be doing better. So if we just move, and if anybody wants to get in touch with me, my handles are below. If anybody feels like they would benefit from any of our support or want to support the people mentioned, then feel free to get in touch. I'd be more than happy to speak. And that's really it from me.
Thank you to all our speakers for really the presentations on, and now we can move on to the panel discussion. I have some questions first for Dr. Rogeshri. You spoke about the impact of stigma, shame, and grief and fear for people with HIV, and what is the impact of this for accessing for HIV medicine services?
I think it's a really massive thing, because HIV is more often than not a sexually transmitted infection. It comes with all the kind of shame and stigma about other sexually transmitted infections. It affects the most marginalised groups. So I think it can cause a lot of self-stigma for people, and often that stigma is intersected with other types of stigma and shame as well. So people, all these kind of things can affect people's ability to access services, for example. Sorry, I'm getting an echo on my thing, so it's just putting me off slightly because I keep hearing what I've just said. Yeah, so stigma and shame is a huge thing. So there's internal self-stigma, and for many people living with HIV, they worry about being seen as being dirty, although we know, you don't it's no one's fault that they get HIV. You just need to have sex once, so anyone can get HIV. It shouldn't be associated with shame or stigma or promiscuity, because anyone can get it. But we know lots of people do face a lot of self-stigma, and the stigma is also external. So we know that people experience stigma from people they know. They experience it from healthcare. They experience it from institutions. So the stigma is also very real and can be externalized. And that can really affect people in the way they access care. So it can put people off for testing, so they may not get diagnosed in the first place. It can put them off from coming into clinic and taking medication. And I work in East London, and we sadly still see many people on the wards with the conditions that we saw in It's a Sin. So we still see AIDS-defining diseases every day. And the people on the wards are often people who have not been engaging with services for a while, because the thought of coming into an HIV service, they worry that people will see them. Taking a pill every day reminds them about their HIV. So it has a huge impact. And we always say, you know, HIV medicine has improved massively since the 80s, but in terms of stigma, we're still stuck there. And although I loved It's a Sin, I think it could have shown how things are now, then it would make a big impact, because I think we still have that old kind of campaign around, which was in the 80s, around the tombstone thing about being ignorant and getting HIV. We need a huge public campaign now to say HIV is a livable condition, and people need to get tested, and that would help reduce stigma.
Thank you. So particularly for South Asian women, what are the obstacles for accessing PrEP and PP for women, and South Asian women in particular?
I guess first of all, knowing that it exists. So you mentioned PrEP, which is pre-exposure prophylaxis, which we mentioned in our presentation. So that is a tablet that you can take every day, which prevents you getting HIV. So a bit like the pill prevents people getting pregnant. PEP, which is the other thing you mentioned, has been around for longer, and that's post-exposure prophylaxis. So that's a course of tablets which you take for 4 weeks, which if you take within 72 hours of having been exposed to HIV can prevent you getting HIV. So first of all, not many people know about either of them. And I think that's one of the main barriers. We're clearly not getting this information in the right way to the right people. So, and I think, you know, many sexual health campaigns have been targeting mainly gay men, and we don't often get this information to women to say, you know, you're at risk as well. And again, when we think about South Asian women in particular, we know that we're not very good at giving very culturally competent information to South Asian communities. So I think, you know, there's a couple of things there, and it's about getting that information out in the right way. And I think there's also something about thinking about, you know, being at risk of getting HIV, being worried that people may think that you are promiscuous because you may be at risk of getting HIV. And again, that I think is something that really acts as a barrier as well.
You mentioned intimate partner violence, and what have been the challenges for South Asian women with HIV when navigating the familial relationships and personal relationships?
I think it's very difficult, and many of the South Asian women who I see living with HIV have not told anyone in their families, and that may be related to a fear of violence. It may be related to a fear of being stigmatized or being cast out from the family, being treated badly, not just by the family but by the wider community as well. And it's always very complicated, I think. So a lot of the women who I look after living with HIV from South Asian communities tend to be married to men. And often the men are having sex with other men outside of marriage, and they're not able to lead their lives openly. And it's a very difficult situation for both the people in that marriage. And I think for women, there's that additional shame of my husband has HIV and now I have HIV, so I cannot talk to anyone about it. And just listening to Neelan speak, and I love listening to Neelan speak because what she says is so powerful and important. The importance of peer support and grassroots community-led action is a real massive thing. And I think HIV has actually led the way in this. Community activists have really pushed the whole treatment agenda, as well as pushing for more holistic care. And in HIV, we do have peer support. So we will offer patients with HIV the chance to talk to someone else living with HIV so that they can talk to someone who's been in their situation. But I have to say, I've never been able to persuade a South Asian woman living with HIV to talk to another peer. And that in itself is very interesting, that they're very worried about being found out about and people finding out that they have HIV.
Okay. I'll pass it over to Daljinder as well.
Thank you for answering those questions. Now to Dr. Selena Singh. I wanted to start off with, although it was touched on through all the presentations, how does South Asian culture affect how patients deal with sexual health? And how can how can the community be more open itself to testing and receiving treatment for sexual health in your opinion and experience?
Thanks. So I think it's quite difficult to give an answer because there are so many reasons. It's really complex, as we know, but I think sexual health issues are often seen as a taboo. So talking about them, seeking help for these sort of things is something that people don't always find very easy. And sometimes there can be a lack of awareness about what problems might affect certain groups. So there was some interesting work that was done in South Asian gay men who felt that if they were having sex with other South Asian gay men, they weren't at risk of infection because they were seen as a sort of almost a safe, separate group. And the same may be true for women. It's difficult to know because we don't have the data. But for some people, there is this sort of perhaps the thought that STIs are something that happen to other people, and perhaps I'm not at risk. And therefore, I don't need to go to a clinic, or I don't need to think about testing, or the problem that I'm having can't be due to infection, or I shouldn't talk about it because it's not something that we discuss openly. So yeah, lots of different reasons, but those could be some of the ones potentially.
And looking at your specific areas of expertise, I'd like to move on to what are the differences in attitudes of young women, potentially South Asian women as well, towards sexual health.
Okay. I just realised I didn't answer your question about communities and what communities can do differently. So I think being open, attending events like this, seeking knowledge, sharing expertise, organisations like Neelam's and listening to people's stories is so important, and just having the conversations are really things that communities can do. But we also know that healthcare providers need to be more inclusive and more open, and that's a lot of work that's happening with that. So moving on to young people, so what's the difference with young people? I think from what I see in my practice, there's more of an acceptance that you should advocate for yourself and that you should speak out about things that are affecting you in younger women as compared to older women. I think the way that younger women access information is different. So there's much more talk about sexual health and issues like endometriosis on social media. There's lots of doctors, nurses, healthcare practitioners doing really great Instagram lives, tutorials, lots on Twitter, Facebook, which is a much easier way for people to access information and to make sure that they're accessing the right information. Because sometimes if you just go on Google, you don't know what you're reading, you don't know who's written it, and it can be all sorts of nonsense. So actually listening to a healthcare professional in a way that's accessible to you, in a format that's accessible to you, is really important. I also think that young women probably don't put up with things as much as older women. So perhaps if they're getting persistent symptoms that are bothering them, they are more empowered and more able to advocate for themselves in some cases. But in other cases, young women may be excluded from services because they're not able to go out by themselves, they're not able to seek help. It's very difficult to walk into a clinic. So we do try and make services inclusive. So some sexual health services will have a dedicated young people service, for example, for 15 to 21-year-olds, where it can feel much more comfortable to go there rather than to go to a clinic and risk running into your next door neighbour or somebody else that you might know who might think, oh, why on earth are you there?
Slightly putting you on the spot here, did you have any resources you'd recommend apart from, of course, Brilliant Sisters? When you mentioned doctors and healthcare advisors sharing content online.
So on Instagram, there's somebody called the Gynae Geek who talks a lot about sexual health, about periods and things like that. I have to think, you are very much putting me on the spot. I can put some things. But there are loads and loads of people doing really excellent stuff, and actually, you know, podcasts, loads of stuff out there that just is really important. So searching for kind of resources that are written by clinicians is important when you're trying to look for information.
The Gone Geek is brilliant, so completely agree.
Yeah.
And then for a final question, what challenges do pregnant women with HIV encounter, including emotional barriers and stigma, as well as additional healthcare needs?
So sorry, it cut out, but was that pregnant women with HIV? What barriers do they face? Yeah. So for pregnant women, it can be difficult because people may not know, but when you're pregnant, you automatically get tested for HIV. And for a lot of women, this can be the first time they're aware of the infection. So not only are you dealing with all the physical and emotional turmoil around pregnancy, you're also suddenly dealing with this new diagnosis. So that can be incredibly difficult. And often people sort of almost have to compartmentalize and get through it. And a lot of women then afterwards have almost like an emotional breakdown when the baby's born and everything's fine. We know that we can prevent transmission of HIV between mother to child really effectively. So if the mum takes treatment during pregnancy, there's a 99-point-something% chance that the baby will be HIV negative. So once they've been through all of that and their baby's born and is healthy and is HIV negative, then they almost have to go through dealing with the diagnosis all over again. And that can be incredibly hard when you're sleep deprived and you're dealing with the newborn and you're dealing with all the anxieties. And again, like Regeshri said, peer support, it's really difficult sometimes to get women to talk to other women because they don't want to identify as being someone living with HIV. And so often the support comes a lot from clinicians, which is good for the medical side of things, but not really for the emotional side of things. And it's really helpful to have representation from your own groups to feel more comfortable in talking and opening up about these things. But yeah, it can be really difficult. But it's just really important to know that there is really good prevention for pregnancy. So women living with HIV have children who are HIV negative.
Yeah, moving on to chatting to Neelam about our presentation. Again, thank you for presenting. Could you chat a bit more, Neelam, about what role you think support groups play in improving awareness and access? Obviously, it's already been praised by your two co-panelists. I'd love to hear more about your perspective. Oh, if it could be unmuted.
I'm so sorry. Could you repeat that really briefly to please touch and touch?
No.
I was trying to press on mute and I wasn't listening then.
Always finding Zoom panels, isn't it? So many tech issues. What role do you think support groups play in improving awareness and access? Obviously, your co-panelists have touched on that, but I'd love to hear about your perspective because it's been quite a journey. Support groups are everything, in all honesty. That peer-to-peer support is so important for that journey. I think it makes you feel less alone. I know with me particularly, I wasn't the only one that had endometriosis or PCOS, and I wasn't the only one that had experienced some of the gaslighting that I did, or some of the medical biases that I had. And it was almost, as much as you're not happy about it, but you could laugh about it with somebody, and that's, we all say laughter's like a healing tool, isn't it? So it's a way to sort of deal with that level of trauma, really. And I think when you've got grassroots levels, related organizations that are really pushing for change internally and breaking that intergenerational issues, I think that's really powerful. And so I'm all for it. Actually, Sisters has some really interesting approaches that I've been reading about. So even bringing healthcare services to people, like places of worship and community spaces. How have you found this experience, and should we even go further?
How have I found the experience? So I will be completely honest with you. We started doing a cervical smear campaign a couple of years ago in places of worship. I'm a Sikh woman, and I was kicked out of one place of worship. As a Sikh woman who is, deeply connected to my faith religiously, spiritually, that was quite hard for me personally. Because I wasn't saying anything wrong, but because of the way it was perceived talking about cervical smears, even though we had a doctor who was a turban-wearing Sikh woman talking about cervical smears, the members of the committee, who are all male, didn't like what we were doing in that space. So what we thought was bringing the service into the community didn't work for us, because the truth is that is not a safe space for people. And it was very hard for me to acknowledge that a place of worship that means a lot to me personally might not be a safe space for everybody. And you know something, it's worked for the better, because we then created the safe space and we brought the people to us and brought the healthcare professionals to the people instead. I'm not saying that we should never approach places of worship to do this. For me, it's working with them probably better. I don't know how that looks at the moment, but I do know it has been difficult. And on a personal level, it obviously is difficult when you're almost rejected by people of your own community. But it is what it is. We just have to do better for the next generation. So we created a different model that worked.
That's really interesting to hear that you got that reaction. Sorry to hear it, but it's a shame that also that's a space where, like, a lot of women from the South Asian background, from that particular background, would feel safe, and that you can't have that relationship with those organisations. I also wanted to touch upon, you've mentioned about Sisters Mission and how that's changed and evolved. And now Sisters Mission is taking up space together. You've talked about the importance of language in creating inclusive spaces. In your experience in setting up a community space, what else has kind of arisen when trying to create an inclusive space?
Transphobia has arisen. A lot of people don't like it. That we believe in inclusivity, and we did not expect any levels of transphobia. I've never experienced it. I remember when we made the changes, it was a no-brainer for me. Being inclusive, having people at the table, it's just a no-brainer. I'm not here to debate anyone's existence, and in my opinion, none of us should be. And it was quite interesting to see the support that we got from the people that were, you know, directly affected and felt seen, but from people that we've never worked with, didn't know, who, I think somebody likened me to, does anybody know Thanos from the Marvel films? Well, someone said that I'd Thanosed half of the UK's population of women. I mean, I don't have that sort of power. How amazing would it be if you could just do something at the click of a finger? So we've received a lot of trolling off the back of being inclusive. But what we've also received is a lot of positive engagement from those that are actually directly affected and needed the support. So it's been an interesting ride for us.
Thank you for sharing that. I've never thought to compare you to Thanos, but that's a pretty interesting reach for some people. A huge alien. Now I would love to finish off with some concluding remarks. If Siddhi wants to introduce each speaker and invite them to their conclusion.
We do have a few questions from the audience as well, so we can come to them afterwards. But if you have any questions, then please feel free to put them in the chat. And if I think the speakers have got concluding remarks from Dr. Ravishri.
Thank you. I actually forgot about this bit, so it's going to be off the top of my head. Apologies. I think it's been a really important conversation because this is a topic that is not talked about enough in South Asian communities. And I think over the last few years, there has been a push to talk about mental health, which has been really important. And obviously we need to do more of that, but it feels like sexual and reproductive health needs to be needs to be addressed as well. And I think particularly within our own communities, as a sexual health and HIV doctor, I'm often trying to get other South Asian doctors to be interested in sexual health, so ones perhaps which are in more positions of power than I am, and it's something they don't talk about as much. It's not seen as being as important. And when we talk about sexual health disparities with regards to racial identity, it's not really identified perhaps that South Asians may be presenting late with HIV, may not be getting sexual health tests, etc. So it's not seen as being as an important issue within our communities. And I think that's something we can all work towards changing by having more of these conversations. And as Selena said, there's loads of great podcasts and things out there, but we need to kind of raise the profile of sexual health in our community. And also just with regards to what Neelam was saying in terms of how can we as the medical community do better in terms of the gaslighting and the bias that we demonstrate, I think change is happening. I'm not sure how fast it is, but certainly off the back of COVID and the Black Lives Matter movement, medical students are being brilliant activists and changing the medical curriculum to include conversations around racism, around sexism, around transphobia, all those things. And I think things will change. And there are certainly lots of doctors out there who are trying to make their colleagues more aware of these issues and how what we do can affect someone's ability to engage with us and to access healthcare. So just to let you know, I think the future is looking brighter, but there's a lot to be done.
Thank you. Dr. Singh, if you had any concluding remarks?
Just come off mute. Thank you. I, again, wasn't prepared for this, so again, it's pretty off the cuff, but I think a huge thank you to both of the hosts for this, because it's so important to have these conversations and get that information out there. We've talked a lot about all sorts of different issues, and it's really important to keep these conversations going and spread the word in whatever format that is. And if people find things like podcasts more accessible, then we need to do more of those. If it's Instagram, then we need to get out there and get the messages across. There are some really great questions in the chat, so I hope we do get some time to answer this, but somebody's written what I think is a really important comment. I think we need to be more proactive rather than simply practice inclusivity ourselves. And that's really definitely a key, I think, for moving forward with these issues. Thank you.
Neelam?
Hello, everyone. So, concluding remarks, I think from a healthcare professional point of view is really center your patient in the conversation. That's for everyone really, and it's really the NHS as a whole. Is recognizing the person holistically. It's really important for us, and that level of confidentiality, I'm going to keep going back to that. For patients that are going through this journey, is that you're not alone. You are seen, you do have a voice, and if you just need help advocating that voice, or you need someone to advocate for you, then we are here, open arms, we got you. So we're just here to support anyone that needs some help on that journey.
Thank you. Now we have some questions in the chat. I think it's possible to unmute yourself. So or I can read them either way. But Makinda, would you like to unmute or? I can ask. I have a.
Sorry, Sudi, it's Laura here. Yeah, I'll have to unmute people. So if you have a question, if you could raise either your own hand or a digital hand, then I'll know to unmute you.
Yep.
Hi everybody, my question's just around the SH24 STI postal test kits. I think you've seen it in the chat as well. I was just wondering if anybody knew why there isn't an option for women to select a swab for oral, to test for oral STIs, or likewise with to do a rectal swab.
So I could probably answer that one. So we do see the highest rates of throat infection with chlamydia and gonorrhea are in men who have sex with men, and it's usually quite low levels in women, and particularly in women who have sex with women. slightly more in heterosexual men, and it's all about the dynamics of essentially than sex between women, particularly oral sex. It is changing though. So there's been some studies done recently actually demonstrate that women do have quite a lot of rectal infection, even if they're not having anal sex. And we're really not sure why that is. We're not sure if when we're doing the swabs, we're picking up perhaps chlamydia and gonorrhea DNA from the vagina, or actually whether it's somehow migrating there. But I think in the future, we will be doing much more what we call triple site testing. So from the genitals, from the throat, and from the anus in women and men.
So we have a question. How should prejudice in the wider community be addressed to prevent the very real consequences of their stigmas, which are just independent, which exist independently of the patient? So just what?
I think for me, it's all about having open conversations, which is going to be difficult. Unlearning is always difficult for people, but it's being uncomfortable with that and, you know, including people in the conversation, explaining why it's important. And I think I'm not saying this is going to happen tomorrow, but I think that's one big step. I think people that are allies need to actually call out bad behavior within their circles. So if they're noticing biases, you know, transphobia, homophobia, etc., they need to call it out. And so we need to take some of that power back by being able to make people accountable around us as well. And I think that will break some of that intergenerational issues around being able to think it's okay to be transphobic or homophobic, etc.
And there's just this bit earlier in that question, which is around how can we reconcile the experience of women on the ground and about examples of disowned testimony. So that's really important, isn't it? We often don't believe the testimonies of what our patients are telling us. So we know that with endometriosis, which is a great example of that it takes on average 8 years until a woman is diagnosed. And that's years of someone going to their healthcare provider and saying, I have terrible pain when I have my periods, or I have terrible pelvic pain. And they're often dismissed as having women's problems, or this is just normal for periods, etc., or accused of it all being in their head. So I think this issue of not being believed and thinking about whose testimony is seen as more credible and whose isn't is a really important issue. And again, I think it's being talked about more, but it's more needs to be done. And I think having the voices of women themselves and of other people in terms of talking about their experiences is really, really vital. So people like sisters who are able to use patient voice and lived experience as a way of feeding back to the medical community what we need to change and what we need to do.
There's a question from Pragya Misra. I don't know if you want to. Shall I read it or? Okay. You mentioned that BV as a sexually facilitated infection, which lesbians have been found to carry a high burden of compared to heterosexual women in research. Could you define the difference between sexually transmitted versus facilitated? And secondly, we know that BV increases risk of future STIs. What role do you think language, specifically in relation to knowledge dissemination, may play in maintaining low risk perception amongst lesbian, bisexual and other WSWs? How might we combat this?
Thank you. So to answer the first bit, BV is not strictly speaking classed as a sexually transmitted infection, because you can have BV in women who've never been sexually active and never had sex. So it's definitely not the only route of transmission, but it is more common in sexually active women, and particularly more common in lesbian and bisexual women. And that may be due to sharing of bacteria. So we talked about the vaginal microbiome and how the makeup of that is individual to all of us. What can happen is during sex and during sharing genital fluids, you can actually transfer those bacteria between women, and the dominant flora in one woman's vagina may become the same in her partner's, and that could be one of the mechanisms, but research is still ongoing. You're absolutely right that having BV does increase your risk of getting other STIs. And it is important. How do we get that message out? I think we just have to keep having the conversations. We have to have information campaigns. It's also important, I think, for healthcare practitioners to know this, because outside of sexual health, for example, GPs and practice nurses may not be so aware and probably still perpetuate the myth that lesbian women are at low risk of STIs. And we still know that people are being turned away when they're asking for sexual health checks because, oh, you don't need it because you don't have sex, meaning penis and vagina sex. So yeah, education. I think that's the way we're going to get through this.
Okay. We have a comment from Gurba Baidal. I'm a GP. I'm horrified to hear of the stories of breaking confidentiality. Even as an openly gay Asian GP, I can sometimes feel that patients don't want to discuss their issues or see me as being part of the institution of healthcare. I think maybe we need to be more proactive rather than simply practice inclusivity. Yeah. So, thanks for this, really valuable. And then how to get, yep, so that's the, that's the link for the for free postal HIV tests, in which Dr. Ravish.
Sorry to interrupt you, Cynthia. I think there's an extra comment.
Sorry, I missed that.
Sorry. Thanks very much. My name's Gaysians, and I'm the GP that just made that comment. I just wanted to add on one little thing, if that's okay. Yeah, two little things. Minor technical issue. When requesting BV testing in primary care, there sometimes seems to be a bit of a barrier. You may or may not be aware. I've not wanted to ask the sexuality team about this. I've had feedback that we specifically have to ask things like clue cells. So it just, I worry that sometimes it doesn't, GPs may not be aware of that. So sometimes there can be a little bit of, I worry about an underdiagnosis of it. I don't know if you're aware of that. I think that was at the Royal London, actually. And I think some of the other labs, but if anyone has any feedback about that, that would be great. That's the first thing. The second thing about that comment, yes, what I meant, which is, I actually did an anonymous survey of people from the queer community to find out what their views are about accessing care from primary care. And people, despite knowing their GP might be very open, a lot of feedback I had was that people still feel that they need to self-censor, which is really sad, because a lot of people that I know, people that I've trained with, are very open and very friendly, but yet being part of the institution means that people still withhold. So I just wanted to share that. That was it. Thank you.
Yeah. So about your question about swabs. So yeah, the microbiologists changed their protocol probably about 5 years ago now, in terms of what they look for when you send a high vaginal swab. So they really only do a culture to look for things like staph and strep, and they don't do microscopy, which is the test for BV, unless you specifically ask for it. So if you've got a patient who you think has got BV, then you have to specifically say. And also if you think you've got a patient who's got thrush, you've got to specifically request that they do a fungal culture, otherwise they don't. If you feel that needs dissemination again, I can certainly go back to the lab and ask them to do that, because we did do a big information push, but I appreciate that was probably quite a while ago.
Okay, so we have a question, sorry. We have a question from Claire saying, how can a white female like myself Soho is an HCP assist in the fight for women. How can a white female like myself assist in the fight for women who are from Black, Asian and minority ethnicities? I attempt at collaborating with staff networks that champion, however, recognise that safe space is needed. I want to do more to help promote and educate myself and others. Sorry.
So shall I start just to say it's about, so thank you so much for that question, and thank you for being here and listening to these conversations. I think just educating yourself and listening to the voices of others, so women from ethnic minority communities, is really, really important. And being, in terms of being an ally, so making sure people have safe space to be able to conduct their conversations. Also giving up space is important sometimes as well. And I think championing other women of colour, and when I think about the people who have most helped me in my career, it has mainly been white women who have championed me, not just in terms of mentoring, but in terms of giving me actual opportunities for me to develop my voice. So I think those, for me, those are some ways in which you can help.
And Trade also running an anonymous or online survey exploring the attitudes of South Asian women towards sex, sexual health and relationships to help shape accessibility to local sexual health and contraceptive information and services as part of Ben's explaining. Sorry, I'm probably getting it completely wrong. But Makinda, is that correct? Or yep. Okay, so and there's the link to the survey as well. Thank you for that. Okay, so I'll I think that we've had many thank yous as well from the audience. I think those are the most of the questions covered. So I just wanted to ask if you feel what can future steps be for having conversations, to keeping having conversations to improve access to sexual health services and HIV testing.
Siddhi, I just want to say thank you for creating this space. You've done amazingly, you and Daljinder, so and all the partners involved. So thank you so much, because without you giving us a space and a voice, we wouldn't have been able to have this conversation today. So thank you so much.
Oh, thank you. Yeah, thank you for your insights and sharing your insights and presentations. I hope will help people who are not being reached by the health service and like, yeah. Daljinder, did you have?
I just wanted to wrap up to say thank you to all our panelists. You've all been brilliant, and to all our attendees. Please do follow all through on social media as they continue to promote this conversation. There's plenty more discussion that needs to be had outside of this 2 hours. Unfortunately, it's just not enough time to go through absolutely everything. But I really wanted to thank all attendees for coming. And Laura, to conclude, I invite Laura to come and conclude today's event, but also thank the LGBT National LGBT Partnership for helping make today happen.
That's great, thank you so much. I just want to extend a huge thank you to the speakers of today and to British Asian LGBTI and to Gaysians. It's such an informative event, I'm sure everybody agrees. And just to thank you all for coming as well and for giving up some of your Friday afternoon to listen to these issues. It's really important that we do make spaces like this to have these conversations and to really dig into these health inequalities and these health issues. So thank you all so much. Just one last thing from me. I just wanted to say that everyone who registered via Eventbrite will receive an email with a feedback form. It's a very brief feedback form, which take about 5 to 10 minutes max, I'd say. And it helps us to put on future events like this, helps us with our funding, helps us with feedback and knowing what we can do better next time. And also you can enter your email address at the bottom of that feedback form and enter into a prize draw to potentially win a £100 gift card. So a nice little incentive there. But just giving us your feedback would be absolutely amazing, because we really thrive on that and it's how we make these events happen. So thank you so much to everybody again, to all the speakers, the organisers and to all the attendees. I think there's nothing else that needs to be said now from Siddhi or Daljinder, is that right? Brilliant, okay. Siddhi, was there anything on your end?
I just wanted to say thank you again to the panelists for really for their insights and thank you to Laura as well. Yeah,
thank you very much,
making this event possible. Yeah.
Great. Well, I will leave you all to the rest of your Friday. Have a lovely weekend, everyone. And yeah, thank you all for coming. Bye.
Thank you all. Bye.
Bye. Bye.